I think the first thing when we think about our patients is look at how the patient moves, because the patient will give us a lot of clues in terms of movement and in terms of how they function, how willing are they to move, to bend, to turn. So I always like to start by looking at the patient. So Mark, if you perhaps just stand up in front of the bench, thanks. And initially just looking at the patient, how do they hold themselves? Are they able to stand up? Are they able to walk into the clinic? And if they come in a wheelchair, then probably you have to do the assessment sitting down or on the bench.
And that's feasible.
And that's absolutely feasible, but I like to have people standing up if possible because it stresses the balance system a little bit more, and therefore I'm going to learn a little bit more from that. Now, some vestibular patients may well have a head tilt, and they'll have a head tilt because they have a loss of function on one side of the vestibular system, which means that the brain will think they're moving towards the stronger side, so instinctively they will tip over towards the weaker side. And so you'll see them sometimes standing that way or even leant over a bit like that. They may also have a head tilt because there's a neurological problem, a brain problem, which can cause a skew deviation of the eyes up and down, and that would be a vertical skew deviation.
Which would be observable.
Which would be observable and would be due to a stroke, so not a vestibular condition. So we need to identify whether there's a skew deviation. If we're looking at the patient, and if the patient is relatively straight, then that's fine, there's no head tilt, there's no problem. I will then do what's called a switching eye cover test, which involves covering the patient's eyes alternately, just looking to see whether there is any vertical movement of the eyes as they refocus on my nose each time. Lateral movements are irrelevant. They just means there's a tropiophoria or something, or a squint. So we're not interested in those. But vertical eye movements, where you see more white above or below one eye, would indicate a central pathology.
Right.
So that would be the first thing to do. Now, if a tilt is present, so for example, Mark, just close your eyes. If I just wobble the patient's head around a little bit, leave you offset to one side, Mark, keep your eyes closed. If you could bring your head back to vertical midline position. Now, that is pretty close. That's close enough for me. So obviously, Mark has no head tilt, no problem. Now, this time, perhaps, Mark, if you just offset it a little bit, leave it to one side. Bring your head to vertical midline position, but get it wrong. Okay, so now we can see the patient has a head tilt. Now that might be due to a brain condition, it might be due to a vestibular or proprioceptive condition. We don't know. At this point...
Just to be clear, he didn't have that head tilt when you first asked him to do that?
Yes, because he may well have just been using his vision to orientate himself to the world.
I see.
So at this point, keeping your eyes closed, Mark, I bring your head back to midline neutral position, and now open your eyes. So now I'm looking to see, are the eyes level? And one eye may be up and one eye may be down due to a vertical skew deviation, which would be a brain condition, but far more likely the eyes will be level, which tells me that that tilt was probably either vestibular in origin or just proprioceptive bad habits.
Right.
Could be
so
either.
If they're not level...
If the eyes are offset vertically, then that would indicate a brain condition.
Right.
Yes, and so should be referred to neurology or MRI scan. So that would be the basic first thing, just sort of the first red flag which we're looking out for. And we're really looking at this stage to differentiate the central causes of pathology from peripheral causes of pathology.
And this is possibly a silly question, but just to make sure it's clear, this is not an urgent referral that's required here. You're not saying, gosh, there must be a stroke about to happen because of that vertical deviation.
It depends upon when the patient presents in respect to the history of their condition. So if, for example, Mark comes in and he said, well, I was fine last week, but yesterday I suddenly became very, very dizzy, and I'm seeing him on day 2 of dizziness, then that could well be, that's an acute situation. So yes, if I saw any red flags, any sort of signs of brain condition, that's off to A&E straight away. So, I'll arrange a taxi and he will go to A&E. If on the other hand, Mark says, well, I've been dizzy for 6 months, and you're seeing some odd signs, well, then that's probably a referral to neurology, and to the GP in a letter or a phone call to the GP to say, take this man seriously.